So this is my agenda. It's a very big topic. I will try to cover most of these topics today, inshallah, within the time given. I have nothing to disclose. So anti-cardiolipin antibody syndrome. The antibodies were first introduced in 1983 by Harris, and he found a strong correlation with thrombosis. In the same year, Hughes found also the same antibodies with correlation with thrombosis and neuro manifestations and abortions. Then in 1999, we got the Sapporo classification criteria. We know classification criteria is not used for clinical practice, it's used for clinical studies. We have the diagnostic criteria. They have more heterogeneous disease features, and they can be used in diagnosis. Sapporo is a city in Japan, in north of Japan. It's the 5th most populous city. It's an old city, 15,000 years. It has a lot of activities. This is how it looks. And this is their university, Hokkaido University. And this is Sapporo Dome with a lot of activities that they do, Olympics and other activities. So then we have Sydney criteria in 2006, and I think we'll get more criteria recent because this does not really cover the disease. So the Disney criteria, we have the clinical criteria, either vascular or obstetric or pregnancy morbidity, and we have the lab criteria. We have to have the autoantibodies at least twice, 12 weeks apart. This is the pregnancy morbidity. In summary, you get one abortion or one death before the 10th week, or 3 deaths, 3 consecutive before the 10th, or 1 after the 10th. So now we come, what if the antibodies are negative? Do we have seronegative antiphospholipid antibody syndrome? These patients, they get the clinical history, but they have negative antibodies. It was first introduced by Graham Hughes and Kamashita in Annals of Rheumatic Diseases in 2003. And they are the patients who have the clinical features, but they don't have the antibody. Why? Is it because we have low titer of the antibody? Is it because they have other antibodies which are not included in the criteria? Or is there a lab error in our lab? They don't follow the standards. So why the antibodies are low? Because maybe they are consumed over time, or because of steroids and non-steroidal, they can get low, or because of thrombosis, they get consumed. And after thrombosis, when thrombosis is treated, they get back positive. Or also in nephrotic syndrome, they can be excreted in the urine. Or lab technique, and it's very well known, lupus anticoagulant, the sample should be completely free of platelets, or it will give a wrong result. We have other antibodies, a lot of other antibodies. These antibodies are found in a lot of patients of seronegative antiphospholipid syndrome, and they are associated with thrombosis and pregnancy morbidity. In a lot of studies here, a lot of thrombosis seen, a lot of studies, pregnancy morbidity. It is found in at least 50% or more, 3%. A lot of studies showed presence of these antibodies in the patients who have either the antibodies or the clinical manifestation, which is thrombosis or pregnancy morbidity. So this antibody is found in thrombosis and pregnancy morbidity also. Now we move to the other topic, which is the non-criteria manifestations. So patients, they have the antibodies, but they have other criteria, and these criteria, they are prevalent in the antiphospholipid syndrome. In this Euro antiphospholipid project, which have more than 1,000 patients, we can see libido is found in 24%, migraine is found in 20%, and thrombocytopenia is found in up to 30% of patients. These are not in the criteria. In this small study, which include 82 patients, We can see migraine is found in 28%, and brain MRI, white matters, is found in 25%, and so on. So these are the manifestations. They are not included in the criteria. They are important manifestations. They are common, prevalent, a lot of manifestations actually. And we'll go over them, a lot of CNS manifestations, common. And I will go over them. This is the obstetric. I will go over them in cutaneous, cardiac, renal, hematological, neurological. I'll just give a brief summary of each. So cutaneous, there is nothing pathognomonic for antiphospholipid syndrome. It can be the initial presentation, and livido is the commonest. This is livido. They can have skin ulcers, they can have rhesmosa rash, they can have thrombophlebitis, they can get superficial vein thrombosis, and they have risk factors treated with anticoagulation, and we have to look for DVT in some patients who have, for example, elderly or previous DVT. If they have superficial thrombosis, you have to look for DVT. This is pyoderma and livido vasculitis. This is the rhesmosa flower and the rhesmosa rash. So, in the cutaneous manifestation, steroids usually doesn't work, and usually anticoagulation. If doesn't work, the anticoagulation, we have other alternatives like sildenafil or IVIG. Then we go to cardiac manifestation. The heart is a major organ affected in the antiphospholipid syndrome. It can affect the valve, valvular heart disease, usually the mitral valve. And antithrombotic agents don't change the progression. Then we have the non-bacterial endocarditis, which is the Lippmann-Sachs endocarditis, first reported by Ziegler in 1888, and then Lippmann and Sachs reported it in 1924. Actually, Lippmann and Sachs, they have a series of 4 patients, and they publish it in the Archives of Internal Medicine. This is their publication. And so it's called Lippmann-Sachs endocarditis. They have small lesions, usually on the mitral valve. It could be asymptomatic, it could be serious. And the treatment is controversial, but the same indication for infective bacterial endocarditis regarding the surgical intervention. Treatment, the primary, warfarin is the gold standard. In the secondary, we use anticoagulation and steroid. But be careful with the steroids, because there are some reports showing that it can lead to fibrosis and valve damage. Echo is very important here, and actually we need serial echoes, multiple echoes. Renal, it could be APS nephropathy or the serious thrombotic microangiopathy. APS nephropathy, usually it's a mild elevation of creatinine with mild hematuria, proteinuria. They can have hypertension, renal artery stenosis. Usually kidney biopsy is useless in antiphospholipid syndrome because there is no immune complex deposition. The treatment of renal manifestation, usually anticoagulation is needed and blood pressure treatment. In the thrombotic microangiopathy, usually they are treated in the ICU setting with plasma exchange and IVIG. Hematological manifestation, we have hemolytic anemia, which is treated with steroids and immune suppression. We have thrombocytopenia, which is usually mild, but it can be serious. It affects up to 50% of patients, usually mild. There is paradoxical increase of thrombosis rather than bleeding here. And treatment, we can use anticoagulation, same as thrombocytopenia. Treatment of thrombocytopenia, usually we use steroids with or without IVIG. If they are refractory, we go to immune suppression. Splenectomy usually is avoided because thrombosis and anticoagulation is not contraindicated here. Why they get thrombocytopenia with thrombosis? Maybe because there is antibody destruction from the syndrome itself or consumption of the platelets. If there is thrombosis and thrombocytopenia, usually we use the usual anticoagulation, but in high-risk patient, we can give aspirin. In this meeting, we have some recommendation that I'll go over. DUACs are very popular because they have fixed dose, predictable outcome, no need for monitoring, but warfarin is the standard treatment. Warfarin is mainly used if there is arterial thrombosis or small vessel thrombosis or triple positive antibodies. If the patient gets more recurrent thrombosis on warfarin, we increase the INR or we move to low molecular weight heparin. We can use fondaparinux, which is available here, and we can add antiplatelets. Antiplatelets are used for primary prevention in asymptomatic carriers, in previous obstetric disease or double, triple antibody. It's used in secondary prevention with anticoagulation if the patient have thrombosis. Rituximab have been used in the non-criteria manifestation like pulmonary hemorrhage. Belimumab, there are no data about it. Fondaparinux is used, it's heparin-like. It's used mainly in HIT, but it can be used also in resistant cases. Neuromanifestation, it could be thrombotic like stroke, it could be diffuse like migraine and headache and chorea and movement disorders. Headache is common, chorea is not rare. Dementia, seizures, management, not well established. Chorea can be used with anticoagulation. For epilepsy, we use antiepileptics. So we'll go over obstetric. This is the old Sydney manifestation. So usually we tell the student abortion is before the week of 20, stillbirth is after. It could be obstetric antiphospholipid syndrome. They have these criteria. They have the antibody. It could be obstetric morbidity antiphospholipid syndrome. They have other criteria, which is mentioned here, or it could be non-criteria in which they don't meet the antibodies. Usually treated with folic acid, calcium, and if there is immobility, we use stockings. Heparin is better than aspirin. The gold standard is that we use aspirin before pregnancy and low molecular weight heparin prophylactic dose with pregnancy. If there is thrombosis, we go into therapeutic dose of low molecular weight heparin. We can use vitamin K, warfarin, and avoid it between 5 and 12. Refractory cases, we use hydroxychloroquine, steroids. We increase the dose of low molecular weight heparin. We use IVIG and plasma exchange. A lot of studies about hydroxychloroquine. Hydroxychloroquine is very popular, especially for rheumatologists. And steroids have been useful, also shown to be useful, and we know the side effects of the steroids, and we have to be careful. They are more with higher doses. IVIG also is used, and these biologics have been used with success in case reports, in case series also, even going to rituximab. Vitamin D is associated, low vitamin D is associated with thrombosis, and vitamin D, it has antithrombotic effect. It is used. Also statins are used and shown also to be useful. So, can we withdraw the anticoagulation after seroconversion? The definition of seroconversion was different in different studies. Some studies say 2 consecutive results. Some studies go up to 9 results. These studies in which they followed these patients, 45, almost half of them, they got rethrombosis while they were on treatment and they were negative. In this series, 10 patients off treatment, only 1 got pulmonary embolism. So it is possible, but you have to choose your patient. You have to follow the patient closely. So we have thrombosis while the patient is taking anticoagulation. We have to check the INR. If it's subtherapeutic, we have to make it therapeutic. If it is therapeutic, we go to high-intensity INR. If it's high intensity, we go to low molecular weight heparin. Vitamin D have to be corrected. Hydroxychloroquine, it is very useful. Statins are used also. Fondaparinux is used. It's mainly used in HIT, but can be used also here. And nothing is known about rituximab. And at the end, I have to say, antiphospholipid syndrome should be followed by internist or hematologist or rheumatologist with the hematologist. Thank you.